Hello guys, welcome to ARBORVITAENXT. Today we are going to discuss about acute sinusitis, also known as rhinosinusitis. So what it is basically, it is the inflammation of lining of the sinuses. So before you go into this, you must read basic anatomy of the sinuses and the physiology part. You can read that from ENT. So let's get into the disease itself. Basically, this acute sinusitis, we call it acute because it lasts usually less than a month. Then we can call it a acute sinusitis, usually from 1 to 4 weeks of time. So it is usually viral in etiology most of the times. The patient will present to you with history of some acute upper respiratory tract infection or history of allergic rhinitis, which can be chronic also, and there may be some history of dental infections. Now, what are the clinical features of acute sinusitis? One feature that the patient will present to you is nasal congestion. If the sinusitis is due to bacterial cause, it might present with purulent nasal discharge. There may be presence of facial pain and with or without headache. There is a fact in relation to the headache. If it is a case of sphenoid sinusitis, there is a headache involving the nasal ridge which radiates to the top of the skull. In case of bacterial sinusitis, halitosis might be present. Halitosis is bad smell from the mouth. In case of maxillary sinusitis, there may be associated teeth pain or abnormal sensation around the teeth, specifically upper molars. On clinical examination, you might find tenderness over the affected sinus. There is a tumor that is known as Pott's puffy tumor. It is nothing but a soft tissue swelling along with pitting edema, which is seen over the frontal bone, and it arises from a communicating subperiosteal abscess, and it is seen in case of frontal sinusitis. Now, about the diagnosis of the sinusitis. The study of choice in case of acute sinusitis, it is coronal CT scans, where opacification of the sinus can be visualized. But if CT scan is not available, X-ray can be done routinely. X-ray PNS, Waters view or occipitomental view is done. There, opacity of the sinus is visualized. Among other investigations, routine blood investigations can reveal signs of infection, changes in complete blood count. A chest X-ray may confirm an acute upper respiratory tract infection. Now, what are the differential diagnoses? Number one, it can be viral or allergic rhinitis. It can be a dental abscess. It can be a dacryocystitis. It can be due to inverting papilloma or sinus carcinoma. It can be a part of cephalalgia, mostly due to cluster headache. What are the complications of acute sinusitis? It can complicate when it produces meningitis. It can lead to epidural abscess. It can lead to cerebral abscesses, orbital cellulitis, cavernous sinus thrombophlebitis. So these are the conditions which can complicate the disease and may need further surgical treatment and other managements. Now, how do you prevent acute sinusitis? In recurrent cases, you can suggest the following things to avoid recurrence of the sinusitis. First and foremost thing, if the patient is a smoker, it is better to avoid smoking, even passive smoking. Secondly, avoid triggers of sinusitis such as various types of allergens. The patient should stay well hydrated. The patient can be advised to irrigate their nose with saline nasal drops whenever they feel it is necessary. They should use masks in dusty environments. They should maintain social distancing and proper hand hygiene like hand wash and use of hand sanitizers. Now, about the management of the disease. So, if the sinuses, the skin above the sinuses are red, hot and swollen, they're extremely tender to palpation and mostly it has been more than 10 days. Still the symptoms persist, so it may be due to staphylococcal origin. In that case, emergent debridement and initial IV antibiotic might be required for the treatment. If the symptoms are mild to moderate and the duration is less than 10 days, it is mostly due to viral etiology and which is self-remitting. So our main goal of treatment is to give symptomatic relief to the patient and we should facilitate the drainage of the sinus. So what we can do is we can give oral or topical nasal decongestants. Nasal decongestant like oxymetazoline, xylometazoline, these can be used for 3 to 5 days, OD or BD, but not more than that, because it can lead to rhinitis medicamentosa. That is another topic. We can discuss it later. But for now, you might remember rhinitis medicamentosa is a condition where this use of these nasal decongestants itself cause rhinitis. And added to this nasal decongestants, we can add nasal saline lavage or nasal saline drops to irrigate the nose. Other options which you can use for symptomatic relief are antihistamines, which can be given orally in case of suspected acute allergic rhinitis, preferably levocetirizine with montelukast. It can be given OD dosing at the bedtime perorally. You can advise steam inhalation with camphor or menthol oil. You can use mucolytics like N-acetylcysteine. You can advise betadine gargle solution to be mixed with water with a same amount of water for gargling. These other options, they have no proper evidence that they are helpful, but they do provide symptomatic relief. If there is any chronic allergic etiology present, the chronic allergic etiology, you can advise nasal glucocorticoids. Now, if the symptoms persist for more than 10 to 14 days or more, then bacterial infection is suspected, and the initial therapy would be with amoxicillin 500 mg with or without clavulanate 125 mg, that is given perorally thrice daily, that is 8 hourly, for 7 to 10 days. If the patient is allergic to penicillin, or there has been recent exposure to antibiotic within last 30 days, or there is any recent treatment failure, then you can advise doxycycline 100 mg perorally twice a day for 7 to 10 days. You can also advise moxifloxacin tablets 400 mg per day perorally for 7 to 10 days. But here you must remember, oral moxifloxacin has risk of tendonitis and neuropathy, so you should use them if actually they are required. For hospital acquired or nosocomial sinusitis, use of broad spectrum antibiotics are required, and also it is better to get an antibiotic or sensitivity done from a deep swab. And for fungal infection, species specific antifungals are used. Example, liposomal amphotericin B for rhizopus, mucor, etc. If after this initial therapy there is no response or the disease is getting more severe, then sinus aspiration or lavage is advised, which should be done by a trained ENT surgeon. Surgical options are for more severe form of the disease or if there is any complication there. The procedure that is preferred to be done is functional endoscopic sinus surgery or FES.